So basically, these are my disclosures. Probably the pertinent ones is I'm a consultant for Medtronic and NuVasive for different types of systems. So we went over yesterday this discussion about the pelvic alignment, and I'm not going to go through that yet again. But we see these different measurements, and I think that at least hopefully if you walk away from this meeting, the thought that at least for fusion cases that you go and you measure these things and have an idea of what your goal should be something that's kind of been ingrained into you. And so basically these shows the different measurements. And the fact is that we discussed these alignment objectives. Now what happens is that for adult deformity in particular, the principal thing that you're looking to correct is sagittal malalignment and loss of lordosis. And as we saw from the new classification for adult scoliosis, the fact is that correcting what you do in the coronal plane has almost no impact on what the outcomes are for surgery. Now, people want to have a pretty looking x-ray. When people come in and they have a bad scoliosis, if their scoliosis is less severe upon completion of your operation, it makes people happy, but it doesn't actually impact very much what their true function is. It's sagittal plane and it's neural decompression if they have neurological symptoms. And if you're able to achieve those, you're going to generally get a good result. So these are the alignment objectives. You can see here, you don't see something that's in the coronal plane. You don't want to make somebody worse. You don't want to coronally imbalance somebody. If they're really coronally imbalanced, you want to get them better. But that is secondary to these objectives. So what's happening is one of the things which is really important to realize is that you want to do it, and everybody's increasingly realizing you want to do it in a physiological manner. And one of the things which I made a mistake, when I look at my cases 10 or 15 years ago, I was saying, okay, we need to get people realigned, and it doesn't really matter where you realign them. And we recognize that essentially the lower you go, the foundation of your realignment has a bigger and bigger impact. And why that is that if you look at different things, that the majority, up to 80% of your lumbar lordosis comes between L4 and S1. So if you're going and making your lordosis at the L1 level, it's not right, and it has some real profound impact as far as things are concerned. So basically, how do we achieve realignment? It's several different things. It starts with the positioning of the patient. I'm going to show you some examples and articles showing it's a profoundly important thing that we do to realign the spine. We want to consider what our foundation is, what we're going to do from L4 to S1, and then we are going to go and deal with kind of the rest of the spine to achieve what other goals that we need to do, and that's typically done through osteotomies. And as I said, the osteotomies are principally focused on the sagittal plane, but again, these same techniques we can use for coronal malalignment, or we can use them for other things like idiopathic scoliosis or Sherman's kyphosis, as you're going to see. So when we talk about the osteotomies, we're going to talk about posterior column osteotomies, and I'll go exactly what that means, and 3-column osteotomies, which include PSOs and vertebral column resection procedures. So what's happening is it's really important, and this is something that I think that that 5 or 10 years ago was really something that wasn't thought of that much. But when I first went to the University of Virginia 13 years ago, I said I wanted something called a Jackson table. And they were like, what? And I said, no, for me to come, I want a Jackson table. So they bought one Jackson table with a lot of grumbling. And we now have 14 Jackson tables at the University of Virginia, okay? And what's happening is if the people, when I first started out, people thought it was ridiculous, and a lot of people were doing stuff on either chest rolls, or they were doing them on an Andrews frame where they were in a kind of kneeling position. And that's why if you look at a lot of operations, a lot of things what David and Kojo and Charlie and Tyler, we do is we revise stuff that was done on Wilson frames years ago because those induced the loss of lumbar lordosis and the consequences of it are coming through. But basically, this study looked at positioning, and what the study found was that there can be a marked change in alignment just by putting them on an operative table. And a lot of the things, as you're going to see now, is that that I've moved away substantially from doing things like pedicle subtraction osteotomies because there's ways of doing things to get the alignment, to do it in a more harmonious manner by positioning, doing releases, giving time, doing some of the other techniques to go do. So basically, what's happening is that the first step is positioning. The second step is deciding what we're going to do with the base of the spine. And we have several different options. And what happens is that there are, what you do a lot of time feeds into what your skill set is to be able to do things. So I think that, during my training, the guy that I trained with was very, very heavily into anterior surgery. And because of that, doing thoracoabdominal approaches and doing a lot of A-lifts was really the major technique that I learned during my fellowship. And so what's happening is that when you do an A-lift procedure, there's some real advantages. You can do an enormous discectomy. I'm going to show you on one of the cases I did. You can release anterior osteophytes. You have to be a little careful because they can be stuck to the vessels, but you can put a really, really big graft in. You can put now, with a lot of the different companies, have hyperlordotic grafts where you can really make a profound change in realignment. And for those people who have a fractional curve, the lowest curve there, which is oftentimes very difficult to correct, you can really release those very, very effectively. So this is a kind of a typical case. This is one of my patients. You can see that severe fractional curve below that almost 90-degree scoliosis. And fixing that fractional curve can be a real problem. If you don't do it right, you pitch the patient off to the side, which can make them very, very unhappy. So this is what I did. I did a couple of A-lifts on the patient. And really, as you can see, had what I thought was a good result on something that was relatively easy. So what I did is I actually broke this up in two stages. I did a little tiny mini open release of the lumbar of the mid lumbar curve. I A-lift the two bottom levels and said that's it for a day. Brought the patient back 72 hours later and did the posterior operation. And for me, I did this with a total blood loss in both procedures of under 1,000 cc's. Whereas if I did this all from behind, this would have been a substantially longer and more bloody operation. So what's the advantage of A-lift? That I think for the average person, you can get greater correction of lordosis at the bottom of the spine by using A-lift techniques. And by putting these large grafts in, you have a very low pseudarthrosis rate, but it is something that that almost everybody needs an access surgeon. And if something goes wrong during an A-lift case, it can really, really go wrong. Okay, and that's the disadvantages of them. So we basically have our choices, and for some general cases, we'll do an A-lift alone. If we want to get greater correction, we'll combine that with a posterior column. It's a Smith-Peterson osteotomy, and you can hook it up even with release higher up, which Juan Uribe has talked about or will talk about. So this is, for me, sort of a typical release that I do for an A-lift. You see the annulus is gone, the disc is gone, and you put a really big graft in. And with this kind of release, you can make a big difference. This is another one of my patients here. You can see the patient's very severely sagittally malaligned. This is a supine x-ray to see how correctable certain things are. And you can see here, there's not a PSO there, okay? I was able to go and make a profound realignment difference by working using hyperlordotic implants at the bottom of there and then doing some posterior column osteotomies. But if you look at this, how physiological the lordosis is, and you'll go and compare this when I'm going to show you some things that I've done with using PSOs. So for me, this is kind of a go-to procedure for me if the spine has not been fused. If it's fused, you don't have a choice. But if you can go and you can release something, you make a difference. So Larry Lenke said that he has not done an anterior procedure. I think now this is 13 years. He's never gone through the front of the spine. And I showed this guy here. This is actually a U.S. senator, and he had a operation done elsewhere. They had a massive dural tear. It ended up getting infected. He had pretty severe meningitis, and they ended up taking the implants out and trying to repair his dura. And he came in looking like that and like this, okay, and you can see the degree of slippage that he had, okay. So Larry may want to go and flog himself by somehow digging through there and doing TLIFs and whatnot in the face of all that. I did this for the patient, which to me seems to be a much more logical thing to do. This guy's back in the Senate and voting against all the policies that I believe in, but that's a little different. Okay, so basically, if you look at the literature for most of it, and this is one of Tyler's papers, that they went and looked at what they did with A-lifts and T-lifts, and they showed that the A-lift did a much better job of restoring lordosis with this. And again, another case of mine, and another case, this actually was bad enough that I had to do, because it was fused in the middle, I had to do a PSO, but doing that A-lift allowed me to get pretty good correction. Again, here's someone with a Harrington rod fusion, and again, being able to do this, and you can see here this collapsed disc and the realignment that the A-lift at least assisted me. Yeah.
Two things. Number one, if you go back to that slide, or go forward to that slide.
Back.
I go the other way. Yeah. So that's almost certainly the mixture of stainless steel with some other.
Yeah, it is for sure. The Harrington rod is the done, and what you can see in there is I've made the mistake of not connecting the two together, and I've had a fracture through the connection point. I've had actually 2 or 3 of those, and so I always hook in the new implant into the old implants, and I use a titanium connector to do that.
Can I say something?
Yeah.
If you guys experience that and you see one of these old Harrington rod systems, you have to remember that very often they're a 7-millimeter diameter. So you have to have an advanced plan for what your connection is going to be.
Yeah, they're at least a quarter inch.
Yeah. 635. So then I don't think we're getting to this. Juan, are you going to talk? Hey, Juan, Dr. Uribe,
He's asleep.
Are you going to give a talk about ACR at some point today? No. Okay. So anterior column reconstruction, which for me an A-lift is that. I don't know if you're going to get to this.
I'm going to show one of Juan's cases. I say thank you, Juan, in the case.
Yeah, but do you want to comment on the difference in blood loss between an A-lift anterior column reconstruction?
Well, I'm going to talk about. I'm going to show you what their article shows about ACR. But what I'm going to say is an A-lift. It's either you lose no blood, okay, that you lose 50 cc's, or you lose 5 liters of blood. There's not much of a middle ground as far as the things are concerned. And in my anesthesiologist, I did an A-lift earlier this week. I did a 2-level A-lift, and the anesthesiologist goes, "Chris, why do you bring a cell saver in? You never need a cell saver." And I said, what's going to happen is the one time I don't bring a cell saver in, they're going to go and we're going to get into the iliac vein, and I'm going to lose 5 liters of blood, and everybody's going to be screaming, "Why didn't you have a cell saver in the room?" So, but I'll talk to you to the point about the thing. So here's another example. This is a patient, and this is an example why I'm not that keen on stopping at L5 in older people. And you can see the patient kind of kyphosed over. And again, the big realignment. This was only just through that one A-lift at the bottom of the spine. And you can see what a huge difference it made going from this to this with just with one change. So we're now to Dr. Uribe's area of expertise. This is doing lateral approaches, and there's a variety of different choices that you can have from those to doing it by itself and doing it with a variety of either posterior column osteotomies or by releasing the anterior longitudinal ligament to do that. And basically, this just goes and shows, this is from David and Adam, that they talk about their ability to correct. At least initially, the lateral approach really, this thing seems to be lateral approach did a very good job of coronal realignment, but the lateral approach by itself was probably not very effective in doing sagittal correction. So because of that, some innovators, Bruzek, Barney, Greg Mundis, and Juan, started doing a procedure where they would actually go in from a lateral approach, release the anterior annulus and the anterior longitudinal ligament. And as you can see, Juan showing from some of his slides how you can actually go and section that and get a much better sagittal plane correction. This is again one of Juan's cases, just showing the type of correction to be able to achieve with a lateral release with this. So this is from Baruz and Greg Mundis showing their experience, and what they found is that by doing this, they could get a correction similar to achieve with a PSO, but with the blood loss from the ACR, to David's point, as you can see, it's essentially, was it 111 milliliters compared to a standard PSO case, which has about 3,000 milliliters. So it is an advantage. Now again, much like the ALIF, if you have a problem though, you can have yourself a real problem. So the last of the simple options is a TLIF, and again, there's a variety of different choices with the TLIF, combining them with osteotomies. And what's happening is TLIF is really something that the outcomes of it, particularly as far as realignment is concerned, is so heavily dominated by the technique that you use. So what happens is most of us from the 90s learned to do a TLIF from Jürgen Harms, and Jürgen Harms, the way he did it was an exceptionally meticulous removal of all the disc and precise placement of the cages, which were used as a cantilever. But usually, particularly us Americans, we'd like to get 4 cases done by 2 o'clock, make it out to the golf course or whatever we want to do. So we're always thinking of ways to cut corners. And unfortunately, much of that corner cutting resulted in techniques that didn't allow the realignment. So if you look at these different studies, and again, if you look at, Tyler's patients, they actually found that TLIF was actually kyphosing across the segments where they did a TLIF. And you can see here, this was their ALIF, their case example from their paper with the ALIF, and here's the case example from the TLIF. And what happened is that this was using a version of the TLIF which was quick and easy, but probably wasn't the TLIF that was ideal for restoring alignment. And what happened is a lot of people at that time didn't think that alignment was very important. You're going to do a 1-level TLIF, who cares? All you want to do is get the thing to fuse. So what's happening was that there's been a gradual realization that to go and to actually make a lordotic segment, that you had to do more than taking one facet joint off and putting something obliquely across the disc space. So this is a paper from Dave Polly, and what he did in his case was to go and use a horizontal kind of banana-shaped implant and take both facet joints off, and as you can see there, he got pretty nice lordosis, and in his case, he got about 5 degrees of lordosis by using that kind of technique. So basically, Charlie and Rod and a few others, they looked at some of the cases that I did, and they said, we thought, that was right around the time the article came out from Tyler and Steve Andra. They said, you seem to be able to get some lordosis. You're not making them more kyphotic. So they looked at it, and what they found is that for me, depending on where the location was, I could get up to 20 degrees of lordosis doing a TLIF. But what I do is, you know, I put them on a Jackson table. I take both facet joints off. I put a you know, banana-shaped cage, and I put it really anteriorly. And what happens is that doing a PLIF positioning or doing an oblique positioning, you're working against yourself. You can't make the segment lordotic. So you can see here, this is a patient from some years ago. I used it as a case example, but just shows you that I take the facet joints off. I do a little bit of initial distracting against the lamina. I put an implant in, and then I cantilever it and compress posteriorly. And you can see here that the patient definitely has more lordosis than we started. And here's probably a bit more profound of an example. 71-year-old, again, really looks pretty bad. And again, I'm looking at the positioning, and this is by doing TLIFs and multiple posterior column osteotomies. So the last portion of the talk is osteotomies, and I think this is the principal workhorse. As you saw from my TLIF and the ALIF, I'm doing facetectomies even after the ALIFs, and I'm doing facetectomies as part of my TLIF to be able to go and to realign the spine. So basically, what type of osteotomy you do depends upon the magnitude of deformity, its location, whether it's focal or global, whether it's flexible, whether it's rigid, whether it's fused, whether they've had previous surgical approaches, and we look into the different pelvic parameters with things. And so, you know, so for me, for at least any major deformity case, I always get supine x-rays to be able to judge the flexibility. So that's in my kind of internal computer about, you know, how much I'm going to do. Can't really see it there, but this is a patient with an x-ray over a bolster there to see if how correctable that kyphotic segment is. You know, I also will take a look at the x-rays after intraoperative positioning, and sometimes I'll even get an x-ray after an hour or two after they've been positioned to see how much correction it is. So this is Larry Lenke's classification of preoperative flexibility. Type A is flexible, type B is stiff. These are, you know, kind of some older, you know, semi-ankylosed spines, and then type C are those people that are essentially fused, that they're not flexible at all. And this is one of Larry's cases, just showing an example of somebody that he was thinking he was going to have to do a PSO, and after positioning and doing some releases, a pretty substantial correction was done. So as we go up through the hierarchy, you know, what we can do is patient positioning gives us some correction. If we compress on our instrumentation, you get some more correction. Then you start to take more and more and more bone off to make the spine more and more flexible to be able to achieve what your alignment goals are going to be. And sometimes you add several of these things together. So basically, this is an article by Frank Schwab, and with a classification of the amount of bone that is removed to go and loosen the spine. So basically, we start off with just doing a partial facet joint resection, then move to completely excising the facet joints, then doing a partial vertebral body, you know, a PSO. That's an extended PSO. Then taking a complete removal of a vertebral body. Then finally to do multiple vertebral bodies to do it. So as you go,
Chris, can I ask you another question about that?
Yeah.
Go back a slide. Do you think that would you advocate switching to this nosology, this terminology, that rather than saying it's a pedicle subtraction osteotomy, calling it a Schwab grade 3 or a Schwab?
I think some things. It's just like the classifications of thoracolumbar fractures. You know, you have all these classifications, and if you want to do a study or write a paper, it's easier to write. There were 8, you know, Schwab 3 PSOs, you know, and 4 Schwab 4 PSOs. That's easier. But when we're talking, it's easier for me to say an extended pedicle subtraction osteotomy. It's like, it was funny. I was on a panel. This is about 8 years ago at the Davos course, the big AO course, and there was 3 people sitting there, and we were talking about the merits of different classifications. And I said, what's a you know, to the three levels. And these are the guys, all the Swiss guys are all doing it. Nobody knew exactly what that was. So some of the stuff, you know, I think from a research perspective or an understanding, I think that Frank did a nice job of doing it. But if if you said, if you asked a lot of people, well, how many Schwab fives did you do? People would start to think, oh, how many VCRs have you done? I think that's for most people more an easier terminology to know. So basically, what you need to do is to sort of match the different types of deformity, the type of osteotomies that you want to do. So what's happening is, and this is a picture from John Dymar, that basically that you do get some correction by positioning alone. That induces some lordosis. And again, I mentioned this article. And what's happening is that just by using instrumentation alone, just by putting this in place and by compressing, even by not taking bone off, you can get some lordosis. The more bone that you take, the greater amount of lordosis you can get if you have some flexibility through the anterior disc space. And again, just some other examples of how that can change. So what happens is that by doing facetectomies and all the different techniques, you can get some pretty profound change in lordosis as that case is done. So basically, the first thing that we have here is a partial facet joint resection. This is generally done for fairly flexible curves where you want to get a little bit more correction. If you want to get even more than this, you take the facet joint out, and this is usually the typical minimum that I do. I'll take an osteotome and take the facet joints out as much as anything else to go and help with the fusion and with the correction. This is now termed, and people asked yesterday the difference between a Ponte and a Smith-Peterson osteotomy. I think that at least in the United States, a lot of the terms are used synonymously. But as I told people yesterday, if you go to Europe and you say Smith-Peterson osteotomy, or if you misspell Smith-Peterson and put in S-O-N, people there absolutely go nuts about it. I've seen people who, it's usually a neurosurgeon and it's usually presenting at the SRS, and you'll get some guy from Germany or Switzerland who just will have a complete conniption over the terminology. And that's why I generally say, particularly outside the United States, just say posterior column osteotomy and you'll save yourself a lot of grief. Basically, these techniques works best when you have a taller mobile disc. And if you have one, you can get 5 to 10 degrees of lordosis. This is the original description of the Smith-Peterson osteotomy by Dr. Smith-Peterson. That's the other thing. It's not two names. It's one person. And basically what he did was he went and did osteotomies principally for correction of ankylosing spondylitis. And here's his original description. And what happened when he used this technique, he fractured the spine. He did an osteoclasis through the front of the spine, and they had several people die through aortic injury. And but this is the technique right here, as you can see. The Ponte procedure, Ponte didn't write very much. It's taken other. This is an article by Harry Schuffelbarger describing a technique which he used for correction of Sherman's kyphosis by removing facet joints in a kind of a wedge manner. And this was him reporting on Ponte's results. This is one of my cases, again, someone with a pretty severe kyphosis, and you can see again the flexibility films there and the intraoperative imaging, and this is a representation of it, and this is what the results were after. And you can see there that again, that was the vast majority of the correction was done through multiple posterior column osteotomies, okay, showing the degree of realignment that you can get. So basically, this is how this technique works by compressing and with removing the facet joints, the ligamentum flavum, and the spinous process through a flexible disc. You can get great correction. So with a Sherman's kyphosis case, you do this at multiple different levels with cantilever bending that results in correction, then compression, and you can get by working through multiple segments, you can get multiple areas compressed. Again, this is a young girl I did about 2 years ago with a Sherman's kyphosis, and again, the type of correction through doing multiple posterior column osteotomies. Next thing up in the hierarchy is the grade 3, which is a partial vertebral body resection or a pedicle subtraction osteotomy. This, a wedge of bone is removed, and this is used to create a closure. The amount of correction is usually somewhere between 20 and 35 degrees, depending upon the technique that's used. It's generally increasingly used for fused segments. Traditionally it was used for flat back correction after Harrington fusion for this. These are just some different studies. This is Bridwell's kind of classic description of the PSO procedure and the results that they got from it. So what's happening here is this is how this works, that you remove a wedge of bone that pivots on the anterior cortex, and this is from Steve Tyler and the group, using a trigonometric method to calculate how much correction you're going to end up being able to achieve with this. So basically this shows you the techniques removing the posterior elements and the pedicles. A wedge of bone is removed, and that's closed to be able to go and get the degree of correction, as you can see here. Okay, so this is again a case. This is the person that had a previous fusion, which I did a PSO. This is from years ago, and again, I think most of us are moving our PSOs lower and lower. Now, you'll see that almost none of my PSO cases now don't have some type of anterior cage, and the reason why is I'm going to show you in the next series of slides. I had to find one because it's been a while since I just did a regular PSO, but now I usually take the superior disc space out to get greater correction, but also to increase the fusion rate. Now, as of a year and a half ago, the RUC that goes and that gives the coding and sort of the payment for codes found that the different codes for 3-column osteotomies were the fastest growing code of any area of medicine, or the second fastest growing code. And the reason why is because people realize you can make money by saying that you did a PSO. And the number of patients that I have come to see me where they're still sagittally imbalanced who said, quote, they had a PSO done where you see the pedicle is still present, you begin to wonder what exactly was done. But even more than that, I think that even when people do have PSOs, it's not a perfect operation, okay? And this is just sort of a classic example. This is a guy who saw me for a fourth opinion. He was an oral surgeon, and every place he went said that he needed to have a PSO done. And they sort of talked about the severe level of complications and all the problems associated with that. So he came to see me, and if you see this guy, these are his flexion extension views. This is a CT scan, and it's my feeling unless someone is fused in the front, they almost never need a PSO. So what I did for him was to do him from behind using multiple posterior column osteotomies, and I did a TLIF at the bottom of the spine, and you can see was able to be fully realigned. And I think I lost 400 cc's of blood in this case. So I mean, the fact is unless you really need to do a PSO, don't do it. The reason why is in most cases it's not physiological. This is a case of mine from years and years ago where I did a PSO at L2 for whatever crazy harebrained reason. Mostly it's because it wasn't scarred in, and it was just easier to do. But you can see here, this is what happens. It's a non-physiological restoration of lordosis. And even though I extended her up, and she ended up doing okay, she would have been much better to have had either a PSO done lower or an alternative procedure avoiding a PSO. So what's happening is that there's a bunch of reasons why we don't get things to realign. Now what's happening is with these 3-column osteotomies, there's a real recognition that we probably underestimated the number of complications. And through the ISSG, we looked at almost a third of the patients, if you followed them out to 5 years, had some type of rod fracture or pseudoarthrosis problem with the PSOs. So because of that, it was looked to see is there a way to improve this, and this was the use of multiple rods across 3-column osteotomy sites. So this is the paper looking at different things where you used basically an accessory rod, and that's putting a side-to-side connector and putting a rod across it and putting 3 or 4 rods with that, or doing something called a satellite rod where you go and you put the screws deep. I think there's a picture of it here. Put the screws deep and then put a rod overlying it. And what it was found was the satellite rods worked better than accessory rods, but all of them were marked improvements compared to two rod constructs. You can, for those people who have coronal imbalance, remove bone asymmetrically, one side more than the other, to get coronal correction. And again, here's a patient with a pretty severe coronal imbalance and realigned through an asymmetrical pedicle subtraction osteotomy. Now, I think many of us are moving to removing the superior end plate and the disc, doing what's called an extended pedicle subtraction osteotomy or a Schwab 4 osteotomy. And with this, even greater correction can be done, but it also reduces the pseudoarthrosis rate by having a cage in that area. Finally, you can remove the entirety of vertebrae to get even greater degrees of correction. The vertebral column resection is best for thoracic abnormalities, is when you need really a big change in alignment. But these are pretty high risk procedures. In one of Larry's recent papers, 1 in 3 of his patients have some type of major monitoring change during the course of the procedure being done. Then finally, you can take multiple vertebral bodies out where you can get the biggest levels of correction. So basically, these are the variety of tools that you have to do major deformity correction. It really starts, I think, at the foundation at the bottom, and I think that's where you should give the most thought to. And then you need to release the rest of the spine to a degree that you can get the alignment goals that you've planned before surgery. So basically, that's the overview of the deformity correction techniques.